Dr. Boyer. Okay. Dr. Boyer recommended that to me. Doesn't disclosure, I have to say, I did not use AI to prepare my talk because nowadays a lot of things just faked. Second of all these images are downloaded from Google, so they should be okay. It is a review article published in AJCC Heart Failure this year, March, so it's relatively new. And there's 9 authors and co-authors in this review paper. Here are their affiliations. They're all Americans. All these are abbreviations you'll be seeing in this discussion. And the most important, I want you to pay attention to cfDNA, that's a cell-free DNA. The other one is GEP, gene expression and profiling. So we'll talk about these two very frequently in this journal club. So here is the highlights. I just read through. Rejection surveillance uses gene expression profiling, and DD stands for donor-derived cell-free DNA. Is inferior to endomyocardial biopsy. I think this statement is very humble, non-bragging. It's non-inferior to the biopsy. Transition away from traditional biopsy surveillance raises many practical questions. In this paper, we provide guidance for the transition and the early implementation process. The clinical value of dd-cDNA may offer benefits beyond current surveillance strategies, pending further prospective studies. I think it's very accurate when we go through this. Just by curious, I searched PubMed, how many related publications. I found 104. As early as 1994, there's one publication about this non-invasive surveillance. And the 2023 is 11. Of course, we have not finished 2023 yet. So it is something there, but not a lot. So some introduction. The EMB, just endomyocardial biopsy, has been the cornerstone for post-heart transplant rejection surveillance since 1970s. But it has limitations, lack of portability, patient's discomfort that I can understand, low inter-observer concurrence of grading. In our institute, we always, most of the time, 90% of the chance, we have 2 faculties, just me and Dr. Boyer read together. So we can reach kind of agreement on the grading. And low sensitivity for AMR, just acute hormonal rejection. More accurate and less invasive method of heart transplant rejection surveillance has been sought out for decades. So in this article, they try to answer 10 questions about the non-invasive method. Explain what is the gene expression profiling. It is a quantitative method. Check the expression of 11 genes in peripheral blood monocytes. And these 11 genes, I think I have a slide to explain more. What are these 11 genes? For DDDF, this is having a mistake, it's supposed to be CF, DDCF, donor-derived cell-free DNA. It's also a quantitative PCR. Has other digital droplet PCR or whole genome sequence, just detect the fragment of the DNA, cell-free DNA in the patient blood, peripheral blood. It is a sensitive strategy with a high negative predicted value. That means when it is negative, the predicted value is very high, 98%, they'll be negative. So it is very good to rule out a rejection. It is very good to rule out rejection. It permits the early detection of rejection, compare the histological change, avoid the sample errors, inter-observer variability in grade, can avoid that. Then it says more timely and accurate. I put a question marker, it's a timely. I think it's not really timely, as we can see as we're going on. The first question, what does the DDDF, why I say DF, CF, DDDF-SS test, and how does it compare with other rejection markers? So first of all, it introduced what is GEP, gene expression profiling. It tested 11 genes because that's the earliest one. The earliest one is used GEP. Then they added the cDNA. So that introduced this first. They checked the 11 genes that involved in lymphocyte activation, cell migration, T cell priming, hematopoietic proliferation, steroid sensitivity, and the platelet activity pathway. So 11 genes related look like T cell activation during the cellular rejection. It's reflective of the recipient immune activation status and is designed to detect the ACR with high sensitivity. Remember, just ACR. So the scores 0 to 40. And later on, the paper will talk about a lot about the threshold. How do you set the threshold? Was created from the Goggle study. Later on, I have slides to introduce all these different studies. The Goggle is one of the studies to distinguish between moderate to severe ACR and quiescence. Not developed to detect the AMR and does not provide information on graft injury. So that's the introduction for the GEP. Then here is the introduction, 11 genes. For cell-free DNA, it's constantly released during normal cell turnover. It's released from dying cells. And with a small fraction coming from heart. I think that's quite understandable, easy to understand. In heart transplant recipient, the allograft released ddcDNA is distinguishable from a recipient CF DNA. That's also very easy to understand because you have a graft in the patient. So this graft will release cell-free DNA as well. Then ddcFDNA is expressed and the percentage of ddCDFA within the total circulating cDNA weight, such as, they give you an example, the sex. The donor and recipient, they may have the different sex. So you can donor to detect the sex mismatch, HLA mismatch, or CNP stands for single nucleotide, I think it's proliferation or fragments or some, yeah, single nucleotide.
Polymorphism.
Oh, yes, polymorphism, single nucleotide polymorphism. So that's give you some example. If you can detect this mismatch, that means you have donor-driven cell-free DNA. With the advent of AlloSure, AlloSure is a test. AlloSure, you have manufactured, that's the test, you can use that. It was noted that increased ddCDFD correlate with biopsy detected rejection. So dd-ctDNA is specific for graft injury. So besides rejection, it can also detect the graft injury with a very high negative predicted volume of 97% for both ACR and AMR. So the dd-cfDNA have a step further than the EGP because it can detect both cellular rejection and hormonal rejection. That's more of that. You need to combine these two, reflect the myocyte damage, therefore help to detect the AMR. dd-cfDNA levels also increased with de novo donor-specific antigen, that's abbreviated DNDSA, further strengthen the link for AMR, help to differentiate false positive versus true GEP elevation in the setting of ACR, further help for detect ACR. So they just list all these advantage of cell-free DNA. Here is in table 1 to give you the introduction of these studies, the previous studies already finished. So this is a very busy table. I don't think we should go through all of that. Just highlight something. You can see the start in 2001, reported in 2007. They set up their differential, mainly is a severe rejection from the quiescent. They have significant p-value here. And the other, as I mentioned earlier, there is, the cargo study has cargo 1 and the cargo 2. Cargo 2 is conducted in 2005, 2009. Basically can detect the greater than 3A with significance. And then there is the largest one is this study. That's OAR is a registration. That is the largest study so far, so 1,500 patients involved. So the largest study on the PEG. The second page is the study involved in cfDNA. The previous one, the study involved the gene expression. Here is the cell-free DNA. Again, it's very busy, so we don't have to go through all of this. I just highlighted the years. I think the most important one is the last one, that is SURE, because it is still going, 2018 to 2024. Still going. I don't know if any of us are involved with this study. I think our institute, I have no idea if we are involved in this study because it involved multiple transplantation center. Here is just a table introduce the assays, the kit or method. The first one is AlloMat, AlloSure, and AlloC. They are from the same company from CareDx. They are located in California, and they tell you what kind of study used their product or kit. I think that there's a lot of limitations for this non-invasive test. I highlighted someone like after the patient have the blood draw, you have to test them within 3 hours. And all these samples have to be kept in cold environment, 6 degrees to 37. You need to have a fridge. And the report 50 to 72 hours. So it's 2 days to 3 days. So I think it's quite slow. Biopsy comes very fast, right? They have biopsy in the morning or report in the afternoon. Here, which is same day report. And for this non-invasive assay, it takes more than 2 days to give a report. So I don't think it's timely. That's my opinion. Again, other test is, you have to do the test blood draw 1 day or 2 days before the biopsy. Otherwise, the biopsy procedure will give you false positive. So you have to blood draw either 1 day before or 1 day after you have the biopsy. Yeah, I just highlight this. I think it's a disadvantage. The other product are from a different company. So Netera is a company in Texas, Austin. The other company is Eurofin, is headquartered in France. It's an international company, covered many hundreds of laboratories spread out in all world. The same issue, they have a long reporting time, and some of them cut out. Why?
What cut out?
What is cut out? My voice?
I can hear you.
Why Dr. Booya comes to tell me it's
I can hear you too.
You can hear me. Can you see my slides?
Yeah. No.
That must be Dr. Booya's computer. It's not my issue. Dr. Booya just pushing on the door, tell me it's cut off. Okay, I think it's too much about the introduction. Just tells you the previous study and what kind of assays are available in the market. Question number 2, what kind of scenario?
We're not seeing your slides right now. You unshared, I think, by accident.
Oh, let me see. Come here, share screen. How about now?
Good.
Good. Okay. So we should move to the second question. What kind of clinical scenario will affect the defect? How do I go to the presentation mode? Okay, good. That's the second question. Actually, there's a table 3 scenarios. And for the GEP part, they listed very easy to understand infections, systemic inflammation disease. Of course, all this inflammation will release a lot of cytokines, all these things. It will affect the gene expression. And another one's, if the patient have a blood transfusion 30 days before, and also steroid dose, because the gene expression has the steroid sensitive gene. So if the patient uses steroid equivalent or more than 20 milligram, it will affect the gene expression. So all these things have to put into consideration when you interpret the gene expression. For the cfDNA, we have ischemic change in the heart. Multiple transplantation, we also do heart and the kidney same time transplant. So they will release a lot of cell-free DNA, so that will affect the result. Bone marrow transplantation will affect, and the pregnant, because you have fetus, you have another foreign source of the cfDNA. So all things have to be.
Can't hear you.
That's your computer. Other people can hear.
Okay, all right.
It's Dr. Booya. So again, sepsis, inflammation, HIV, and cancer. All these situations have to put into consideration when you interpret your test. So that is important to interpret this result within the clinical context to determine whether a confirmed biopsy is required. So I have to case by case decision. Yeah. Incorporate with the additional clinical data. I think that's very important. Third question, how should the transplant program determine the threshold for abnormal gene expression and the cell-free DNA? What is the abnormal value? Excuse me. Hello? Oh, can you call Dr. Saluja, please? Because I'm in the middle of conference. I forgot to this. I was called for frozen anyway. That's the third question, what is the threshold? So the answer is very simple, it's no absolute value. You have to, it's definitely abnormal. And the different transplant program, the research study have used a different level, depends on the surveillance strategy and the patient population. So that is the answer. So you have to balance between test sensitivity and the specificity. And here they gave you a table. So if both are normal, there's no unlikely to have rejection. If both are high, likely to have a rejection. And the percentage in DORA, that is the largest study, the registration. So in the largest staging, then both normal at a very high, more than half of a percentage, both high, strongly likelihood to have rejection is very small number. Then also you have to put the time after status post of transplantation, 2 months to 6 months is less than 30. If the beyond 6 months, the threshold is 34. So the threshold have to be determined as status post the time. And the cell-free DNA, the threshold is less than 0.12%. And the graft damage is greater than 0.2. So that just give you an example of the threshold. Here is more numbers. Well, just look at the table. I think that's understandable. If your threshold is set high, you lost your sensitivity, you bring up your specificity, right? So if you set the numbers is your threshold, and your positive predictive value decrease, but your negative predictive values increase. The same thing as a cell-free DNA. If you set a very high level, then your specificity increase, your sensitivity dropped. Your positive predicted value increase and the negative predicted value will decrease. That means some of the positive you will lose it, and specificity increased and sensitivity decrease. So that's give you an example to set up a threshold. But each center have to determine that by your confidence in your experience. The fourth question is, how should the program decide the post heart transplant timing, the timing, when it should start and how frequent you should do that? The performance of the gene expression score can be affected by the administration of a corticosteroid due to effect on the expression of steroid representative genes. And so the earliest opportunity for gene expression is 35 days post heart transplant. So that is almost 2 months. 2 months after the transplant, as long as the prednisone dose is less than 20 milligrams per day. If you use higher dose, and you cannot use this gene expression. Stability of the cell-free DNA assay has been demonstrated starting at approximately 14 days post-heart transplant in both studies. Some centers started cell-free DNA surveillance as early as 3 to 4 weeks. 3 weeks will be 21 days, 4 weeks to 28 days. I think that's pretty delayed. In our institute, they started doing biopsy like 1 week after heart transplant. Then we do 1 week at a time in the first month. So I think the non-invasive surveillance is much delayed than heart transplant biopsies. Again, that tells you some of the results from the previous study after 55 days. The number of biopsy remains within the first year surveillance protocol depend upon factors as perceived rejection risk for individual patient, the overall population, the level of clinician confident with non-invasive testing, the availability of resources. That means in the first year, we still need to do the biopsies because a lot of center doesn't have the resource and the clinicians are not comfortable with the non-invasive test and the population. So that is this question. They talk about the gene expression score is higher in 2 to 5 years than it will be the first 6 months due to the lower intensity of immunosuppressant further from the time of transplantation. So the immunosuppressant will affect the gene expression score. There is currently no evidence base supporting the use of a non-invasive surveillance test in heart transplant recipient beyond 5 years of transplantation. Some centers do use cell-free DNA to detect the allograft injury in patients beyond 5 years. Some centers use the cell-free DNA, not the gene expression. During the COVID pandemic, transition away from traditional biopsy surveillance protocol towards a less invasive procedure has accelerated. So during the 3 years of COVID pandemic, so more people switched to non-invasive surveillance. So question number 5, does cardiac image needed to perform each non-biopsy screen visit? Do we need echo? Answers to the question number 5, there's currently no consensus whether cardiac image should be concurrently performed to each non-invasive rejection screen. So no consensus about that. Because the heart function, ejection fraction does not add additional volume to the ACR. I don't know if our center do that. I think the simple answer is that no consensus to that question. Question number 6, how does the time course and the degree of cfDNA elevated differ between ACR and the AMR? I think that's a very useful question. If they do cell-free DNA, is there any difference between ACR and AMR? So the current commercially available assays for cell-free DNA measurement are not able to tell differences between these two. So that is not good. From other cost of allograft injury, Several studies have now demonstrated that some study demonstrated the cell-free DNA elevation precede the histopathological diagnosis of both AMR and ACR. Cannot tell them apart. As well as allographic dysfunction by a median of 3 to 5 months precede this rejection. Therefore, in clinical practice, cell-free DNA elevation provides a unique opportunity for interpreting the injury process before the onset of biopsy-confined rejection or graphic dysfunction. So give you an opportunity because it's earlier than your biopsy positive, but cannot tell ACR versus AMR. So here I just give you 2 examples. One is the DOR, that is a donor-driven outcome allograft registration study. In this study, the biopsy-proven defined rejection was very low. It's only 4%. In their study, no statistically significant between the median DNA level in between ACR and AMR. It is a small study, small case. They cannot tell AMR from ACR by cell-free DNA. But in another study, Genomic Research Alliance for Transplantation Study, they say they can tell. AMR and ACR displayed unique and dichotomous cell-free DNA pattern. They can tell AMR from ACR. But unfortunately, their assay is a research grade assay. It's very complicated, very restricted. So it is not certain whether future clinical available. It is research grade assay. I think it's more sophisticated. Question number 7. Can cell-free DNA be used to risk stratify patients with the de novo DSA, donor-specific antigen formation? First of all, we have to be sure you separate these two, cell-free DNA versus de novo donor-specific antigen, donor-specific antigen, separate them apart. Besides the development of de novo DNA in probably 1/3 of the transplant recipient, only a little bit more than half of this patient will develop biopsy-detected AMR. So only a small portion of patient will develop biopsy-proved AMR, so very small portion. So it is likely the immune system-mediated allograft injury proceeds incurred by pathological begins and microvasculature as an indolent process. So you develop the antibody, but only small of these patients will have a biopsy-proven AMR. So most of the patients, you don't see the rejection. That is very indolent process. Let's try to say that. It raises the question of whether cell-free DNA can detect the allograft injection from pathological donor-specific antigen and thereby guide the treatment decision. So if the donor-specific antigen has a lot of indolent process, then the question is, can the cell-free DNA add some value to that, can detect? So I think I'll go through that. Let me give you 2 examples, some studies. In one of the analyses of 61 samples from a short registration with valuable DNA levels and the negative paired biopsy, the cell-free DNA levels greater than 0.15% were associated with the four-fold greater likelihood of subsequent antibody detected within the first. So that means the cell-free DNA, when the threshold is 0.15, it did predicted the likelihood of a further detection. It did add some value to that, but the threshold is 0.15. In another study, 67 patients showed the patient with donor-specific antibody had a higher level of cell-free DNA compared with those with preformed donor-specific antigen and those without. So that means it did add significant value to the donor-specific antibody alone. So cell-free DNA did correlate with quite well. So their conclusion to this question is, again, no current consensus on whether a cell-free DNA elevation in the presence of a donor-specific antigen and the normal allograft function should trigger treatment. So no consensus on this question. I think it's kind of, everything is uncertain. That's what I feel. Move on, question number 8. What can cell-free DNA tell us about graft healthy beyond the present rejection? That's a good question. Beyond the rejection, what else you can tell us? So cell-free DNA, donor-derived cell-free DNA reflects any form of allograft injury and is not specifically to rejection. Thus, donor-derived cell-free DNA has also been applied to graft health in a broad sense. So that answers the question. Besides rejection, it give you more information about the graft health. And again, give you some example of the study. Yeah, one is I don't know how to say, that is one study and one study from Spain that tells you when the graft is not healthy, the cell-free DNA also elevated without rejection. Again, it is currently unknown whether the relationship between elevated donor-derived cell-free DNA and the clinical event is no current knowledge. Further study are needed. I move a little bit faster because I think we need some time to discuss. This one, what logistic challenges may transplant program encountered when you should adopt this non-invasive screen? So first of all, you have to educate your team about use this non-invasive blood type monitoring and interpretation. The time is important. So when you take the blood draw, it should be before or after you do the biopsy. And the gene expression must be processed in a specific lab within 3 hours of blood collection, and it cannot be transferred by the hospital tube system. So you have to be specific delivering, and to be 3 hours and a specific lab. So probably most of the center will not have these resources. They're making things more complicated. And donor-derived cell-free DNA assay can be only reimbursed outside patient in USA. That's quite strange. I don't know why. And cost efficiency of non-invasive test as compared to biopsy has not been analyzed, the cost. So that's also challenges. Question number 10, which heart transplant recipient may be appropriate for non-invasive surveillance protocol? So that's the last question. What kind of patient? It is something like you cannot apply to every patient. So most of the data clinical experience with the initial gene expression study exists in low rejection risk cohort. So previous study or down in the patient have a lower rejection population. That means you have to exclude, you have graft dysfunction, you have a severe allograft visible vasculopathy, rejection therapy greater than 2R. The patient have a previous rejection 2R within the preceding 2 months. History of hormonal rejection, present of donor-specific antigen, prednisone dose greater than 20 milligrams per day, hemolytic growth factor or blood transfusion within the previous 30 days, and pregnant. So you have to exclude all of this. Basically, considerable perform the non-invasive surveillance for very stable. The patient have to be very stable transplant patient. Exclude the high-risk patient population. So regardless of the individual patient risk, it is important to note that the gene expression and the cell-free DNA assay are intended to use as a screen test, in stable transplant recipient. So I think that is very good to know. So using low rejection population as a screen. I think later on they gave, this low rejection risk and a high rejection. I would be talked about that. Then they give you they call the centerpiece. It's kind of a very complicated figure, but you can start from the top line. You have normal DNA elevated gene expression. You can go straight to biopsy or watch. So if basically they put more weight on the cell frame DNA. If the cell frame DNA elevated, and you probably more likelihood to do the biopsies. If the cell frame DNA is normal, just elevated the gene expression, you can do watch or optional to do the biopsy. Of course, if there's biopsy proved rejection, you have to start treatment. Here, this rejection. If the biopsy is still negative, but you keep elevated, the cell-free DNA remains elevated, then you have to think about other things, other possibilities, the synovials of the interfering factors, then determine, because the biopsy is still the cornerstone. I think the biopsy is still the cornerstone as the surveillance. Again, the summary of the key point, I think it's too much. Finish the puzzle. If you're interested in, just read that afterward. This there's other methods on the market as well, but it's not included in this article. Methylation, microRNA, protein biomarker, which is a troponin and the other proteins, extracellular vesicles, and donor-specific antibody. There's another non-invasive surveillance test available now, but much less studied. Those are not involved in this article. I think I finished here, leave some time for discussion. I don't know if I said that clearly because it's very, I think it's complicated.
I agree. It's a complicated paper. I have a couple of questions. One question for the cell-free donor-specific DNA. Did any of the studies take into account, what the clearance rate is of these molecules in the body? In other words, if someone has renal failure, for example, do they hold on to this? Or do they get a higher level? Did any of the studies that you came across deal with that issue?
I think you have to exclude that population. The multiple organ transplant, they were mixed up cell-free DNA, mixed together.
But I'm not talking about multiple. No, I'm not talking about multiple. I'm talking about, say, someone like cyclosporin-induced renal failure. They still have their native kidneys. But, just like we adjust other drugs because they have different clearance mechanisms, if you have impaired kidneys, not necessarily transplanted kidneys. But did they talk about that?
No, they didn't mention drug-induced. They just mentioned a multi-organ transplantation. You have to exclude that. I think that's, it's something to add on. It looks like everything is not certain, need more study. And any of us here involved in this kind of non-invasive surveillance tests?
Not directly.
Yeah, actually, I have a follow-up question from David. So you mentioned they have to exclude many populations, they clearly delineated. And then you say you have to interpret this in uncertain situation, including inflammation, including infection. So any data, how many of the reading is consideration of this or excluded out? Do they disclose that information when they do non-invasive? How many people have to be excluded or correlated with other tests?
I think let me move back. Let me still share my screen. I think I have a list of that's called the high-risk population here, but it didn't mention drug-induced. They have previous rejection, DSA level, pregnancy. I don't know. Did I answer your question or?
I just want to know how many percentage of your tests have to correlate with other tests, for example, like inflammation markers or anything else.
They didn't say the percentage. They just say you should consider these kind of things.
Of course.
And these patients you have to exclude, but they didn't say percentage. You mean
thank you. Yeah, I understand.
Among the total transplant population, right?
Yeah.
I think each institute will be different.
Yeah. Any rationale for pregnancy being an exclusion?
Just the baby. Baby is kind of will release some cell-free DNA as well.
But I guess then that brings up another question. What genes are they looking for? Because I'm assuming you could find genes that are specific to the donor and not to your pregnancy.
I give some examples like a sex chromosome, Y and X, because the baby will have different sex with the mom. And also HLA.
So David, they're looking at DNA, which is not genes. They're just looking for regions of the DNA which will be different.
Yes, short fragment. It's called cell-free.
Cell-free DNA, but quite variable DNA.
But are you saying they're looking for DNA that's different from the recipient and not distinguishing what the origin is?
So that's called the DD, the donor-derived cDNA.
But see, if it's donor derived, you would think that they should be able to distinguish from the pregnancy. But maybe not.
For example, if the mother was carrying a boy during pregnancy and the donor was a male donor, the discovery of Y chromosome DNA, and the absence of pregnancy would say that's coming from the donor heart.
Sure.
Now it's complicated.
Yeah, no, I understand that. So, but I mean, I would think they would pick some other genes other than maybe sex genes or something like that,
Yeah, so they call the
So are they tailoring the, I guess,
pleomorphism.
yeah, are they tailoring the types of DNA that they're looking for based on the nature of the transplant and the nature of the patient?
Yes, certainly,
Okay.
because they was
Okay.
PCR based, so they must have specific genes. So for the GEP, the gene expression file, they have 11 genes. For the cell-free DNA, they must have a panel. What kind of gene? Usually hundreds of them.
Okay.
So cell-free DNA, they usually have hundreds of fragments. You have to use the specific primer to do the sequence to detect that. But of course, we cannot go details. That's different area. It's a kind of essay, more detailed.
So I have a couple of comments. First of all, thank you for the presentation of a very important paper, I think, to all of us. I have a lot of history with the gene expression profile. Years ago, I had someone from the company who had basically admitted it was a placebo for the clinicians, so they could do something for these patients. But the test itself, if you look, I mean, it has no negative predictive value differences anywhere across the full range of scores. And if you go back to the original New England Journal of Medicine paper and go dig deep into it, you'll see that it's as good as a pregnancy test in men. Just, it doesn't work. The cell-free DNA part has been more intriguing. At least they were able to utilize the money they raised from the gene expression profile for the cell-free. But as you pointed out, it still doesn't distinguish between AMR and ACR. So going down that route just delays the appropriate treatment of the patient, because you send something off to the company, you get a result back, and it's elevated. Then they have to do a biopsy to distinguish AMR or ACR, or maybe they can use DSA at some level. But the ultimate important information is still being delayed. And it's just, it's been amazing to me that our clinical colleagues are just so adamant that they want a blood-based test, which does sound great in practice, but the reality is these tests are not as good at making that key distinction between ACR and AMR, which are treated differently, or even just making the proper diagnosis of rejection. I'm going to get off my soapbox now and let someone else chime in.
So I have a question, follow-up question to you, Mark. Are most of these tests being done by separate companies? I mean, the companies are not licensing the actual testing equipment to the actual hospital pathology department?
Yeah, there's one company called CareDx, which has the AlloMap test out in California, as was stated. And so you mail them the blood of the patient. You do everything there. And their price is pretty darn high for what they offer, but it's identified that they figured out what they could charge, that with a certain amount of follow-up of biopsies, it comes out about the same as if you were to biopsy everyone. But the reality is, with the success that our clinicians have in keeping antibody rejection at incredibly low levels over the last 10 or 15 years because of better protocols, we don't need to be biopsying our patients years and years down the road routinely, only if there's a reason. And it would save everybody money if we're not doing that, and also not ordering this test, but simply going to trigger a biopsy as soon as there's a reason, any need, I think should be the reason to biopsy someone. Okay.
I must say I have a little bit of trepidation about sending stuff off to a company like that. It almost sounds like a black box thing. I've just finished reading a history of Theranos, and I'm hoping we're not dealing with that sort of situation.
I think the turnaround time is too long.
Yeah.
Our physicians, it looks like they need they wish you had a result in 5 minutes. They give you the tissue, you told me it's a rejection or not. We do that. Sometimes we'll have to do frozen. to give you
So
the
the authors get credit for having a provocative title, but the answer is the biopsy's not dead.
no.
I just
That's what I said at
noticed.
the beginning.
I just noticed many of the authors are consultant or got their funding from the company. Yeah, that's another part. So maybe it's a lot of discussion. Actually, I have a couple more questions, but you know, maybe we can talking about that over the emails or the phones. So thank you so much. Any more questions?
I think the chat box has some question. Yeah.
Yeah.
Onto those negative protective value, essentially they're the same regardless of the.
Yeah, that was my while you
Oh,
were
oh.
presenting, just pointing out that it's all 98%. In fact, if I can, I would just want to share something real quickly as we head out the door. That's all right.
Yeah.
Which is this is our COVID test at Hopkins during COVID. This is PCR test, and a normal good functioning test has a clear threshold of negatives and positives, and so these are all the positive cases. And then as you get up to 40, that's a bunch of negative. That number would be off the chart because that's 45,000. This is only 450, but there's a clear gap between the two. So the opposite of a successful test would be a normal distribution. And this is the normal distribution in the New England Journal of Medicine paper for the AlloMap test. And this is the threshold they picked. They changed the threshold only to reduce the number of biopsies being performed,
Wow.
not because it performed any better. It had the same positive and negative predictive values. That was unchanged. So again, it always helps to read deep into a paper and supplemental material.
So our job is secured.
Yes.
No, it's not, because our clinicians need to be informed. And if we don't inform our clinicians why the biopsy is still superior, we're not, our jobs are not safe, because they will still do silly things because they don't know better.
Maybe we should generate a paper. Pathologists, like putting
Well,
the high.
you can, I think all these tests is just too, one way they said the test has to be done 3 hours after the blood draw, but you have to ship the sample to your company. How can you make the 3 hours? I don't understand. So you have only done this in California, right? Other places you have no way. Or in Austin, there's a company in Austin. So the other centers, almost impossible to send a blood sample in 3 hours. And no cost.
Yeah, you trigger a lot of questions beyond. So a lot of questions will send to you, and then you hopefully you can have answers. But thank you so much for a great talk. Triggers many thoughts. Thank you, Mark.
Thank you.
Thank you. Have a good day. Bye-bye.
Take care.